All right, so we are about to talk about a drug that is definitely near and dear to our hearts. One that I did not have when I first started, but I can tell you there was some times we definitely needed it, and that is succinylcholine. Now, succinylcholine, and this is one of these drugs you absolutely have to know backwards and forwards. And the reason that I say that is because when we are using this drug, we are using it and we're kind of breaking the first rule of medicine in doing so. And what I mean by that is that we are actually taking away, we are paralyzing the person with this drug. So it is absolutely imperative that you know this drug backwards, forwards, left, right, know what it can cause, what it can't cause. So this drug is also known as a nectine. That's what you usually see it. And again, one of the things I want to point out is up here up top, it usually says paralytic drug. So make sure that you, especially when we usually keep it in our Knox box. And because we keep it in our Knox box, again, so that we don't confuse it with other drugs. One other thing about this drug is that everybody says, well, I call it sucks. Call it succinylcholine. And the reason that I say that is that call it what it's supposed to be called. And a lot of people, especially on the reports, they'll write sucks. And it's like, yeah, it's wonderful to shorthand it, except that's not its name. And if you're going to shorthand it, use a nectine. So, again, we use it as a short-term depolarizing skeletal muscle relaxant. It paralyzes for around 5 to 10 minutes. And it does this at the synaptic level, but it also causes some major potassium shifts in doing this. Which is why we're going to talk about some of the side effects of this drug a little bit later. The key thing about this drug is it's a depolarizing agent, and it lasts for around 5 to 10 minutes. So if something bad does happen when we're trying to place it in the tracheal tube, and that's the primary reason we use this is to paralyze somebody to do a drug-assisted intubation. The other term that is used is rapid sequence induction. There's nothing rapid about it. It's drug-facilitated intubation. So again, it's a sympathomimetic, it's a neuromuscular blocking agent, but it's a depolarizing agent. As a depolarizing agent, it only lasts for around 5 to 10 minutes. And again, it's a paralytic drug. So again, the actions is that it paralyzes skeletal muscle, and it paralyzes all of them. So it paralyzes your muscles that were involved in breathing. It paralyzes every muscle in your body. The key word with that is it doesn't sedate the person. And so literally, if you were to give this drug and not sedate somebody before you did so, they would be fully awake and not able to move. And how terrifying, absolutely terrifying that would be. The other part of this is that it has no effect on consciousness, pain, or any seizures. So if the person's having seizures and you've given them a sedative, a benzodiazepine, Valium, Versed, Ativan, and they're still not seizing, and then you say, well, I'm going to give them succinylcholine to stop their seizure. You'll stop the muscles from moving, but you won't actually stop the seizure. The person will still technically be having the seizure in their brain. It's just that the fact that they're still going to be able to move. So we don't use it for any type of seizure activity. Now, again, onset is 1 to 2 minutes. And when you give this drug, you push this drug usually over about 30 to 45 seconds. And when you do so, you're going to see what they call fasciculations. Everything is going to depolarize. And then for 5 to 10 minutes at that point, you're going to have the muscles literally cannot move at that point. And I will tell you, by the way, it's usually, especially if they're hyped up on drugs, it's usually more towards the 5. If they're having some sort of head injury problem, it's probably more towards the 5-minute mark that you're going to have that with. So, again, we use it to get rapid sequence intubation. And we also, you can use it to stop laryngospasms and to promote muscle relaxation. And they actually use it to help facilitate shock therapy, like if you had to cardiovert somebody, but it's kind of like a really extreme measure to use it for. So again, one of the biggest problems with giving sucks is that it's got some major side effects. Besides the fact that it stops you from breathing completely. You are then responsible for making sure that this person breathes. It will increase intracranial pressure when you give it. And it has prolonged paralysis. That's kind of a side effect. It can go a little bit longer than 10 minutes in some cases. The side effects, as far as cardiovascular, are usually due to the patient's not getting oxygen. That's the biggest problem. With that being said, the other problem that you have is if you give this to an asthmatic, especially a status asthmaticus patient, they're going to have bronchospasms, they're going to wheeze even more, and they're probably going to get worse. I would say, and all of the paralytics will do this, but succinylcholine especially will do it. And the reason that they vomit is because, again, you're relaxing every muscle in their body, which includes the pyloric sphincter. So therefore, the food's going to come right back up. So again, that's one of the things when we do RSI, we tell you, do you want to maintain a certain degree of crike pressure? And the reason is so that you basically occlude the esophagus, because remember, everything is relaxed. Now, malignant hyperthermia, what happens is we get a potassium shift at the cell level, and it causes the temperature to spike and very rapidly. If you have a patient and they know that they've got a history of this, SUX is absolutely out. We do not want to do that. If they have hyperkalemia, we don't want to do it, because all of these things, because SUX can cause all of these problems. So the succinylcholine will cause all of these issues. Now, I will tell you that Dr. Frank will very specifically ask you about these when he's doing your interviews. I would absolutely know these. Again, a penetrating eye injury, we don't give it. If they know they've got a history of malignant hyperthermia, absolutely do not give this drug. If they have chronic paralysis of their limbs, spinal cord break, something of that nature, you want to stay away from it. They usually have elevated potassium levels. If they've been entrapped for 2 hours or longer, definitely don't want to give this drug. And again, if they know, that they have hyperkalemia, don't give this drug. Don't. Now, do we have a chance to find this stuff out? The malignant hyperthermia, I would absolutely find out if I could, if I'm talking to a conscious patient. I would absolutely find out to make sure. Matter of fact, I might even ask them as I'm explaining what's going on, have you ever had your fever spike really, really quick, and they told you that you have malignant hyperthermia? Usually, by the way, people find out that they have malignant hyperthermia because they give them SUX, and their temperatures, again, go through the roof. Now, if they've got asthma, that's a relative contraindication. If they've been burned, a lot of people say, well, they've been burned, they can't have SUX. That's not true. It's usually the potassium shift occurs somewhere after like 3 to 5 days. So, and this one even says 7 to 10 days. If they've got glaucoma, that's kind of one, again, the succinylcholine will increase intraocular pressure. So therefore, we don't want to increase it even more. It could cause blindness. So you got to be careful with your glaucoma patients. Now, all these drugs, they can potentiate, again, take a good look at the list, but we kind of give lidocaine to help the spike of intracranial pressure. So, but it also helps facilitate the intubation. Diazepam, that's why we usually don't use Valium when we do an RSI, because we don't want it kind of counteracts the diazepam. If they're on a cardiac glycoside, digoxin, you might see some more dysrhythmias that you're supposed to know. Now, there's a reason these are all highlighted in yellow, and you make sure that you know this. If they are conscious, you need to explain what's about to happen. Now, hopefully you have sedated this patient where they do not remember it. Again, if they are using a pediatric patient, you want to use atropine. You want to pre-medicate them with atropine, and then you also want to repeat the doses of atropine, because we do not want bradycardia during that event. Even though we bag them very well, and we ventilate very well, the point is make sure that heart rate doesn't drop, because when that heart rate drops, so will the blood pressure. It's not good. And then pre-medicating with lidocaine can slow down that increase in intracranial pressure. I want to stress this. It does not decrease intracranial pressure. It prevents the spike of the intracranial pressure. So again, succinylcholine produces paralysis. It does nothing for pain. It does nothing for sedation. So before you RSI somebody, give them medicine for pain, whether it be a fentanyl, Dilaudid, morphine, something for the pain. The other thing you need to do is make sure that they are sedated. Ativan, etomidate, Versed. It kind of depends on what situation. Ketamine can also be used for this as well. So again, but once you push, just understand that once you push succinylcholine, you're going to have to watch that airway like a hawk. You're going to be breathing for that patient. All right. Again, if you got brain or spinal cord injuries, it can prolong the effects of succinylcholine. And again, and it will not stop neuronal seizure activity. So again, we don't give this to stop somebody's seizure. Now, the reason I highlighted this is because, again, most of the time, most of the sucks that we use in the field is 200 milligrams in a 10 ml ampule. That's kind of the standard dosing. I've seen this one a little bit, but for the most part, we see 200 milligrams in 10 mLs. All right, dosing. 1 to 1.5 milligrams per kilogram, and you could repeat it once. I'm of the mindset, if you're going to go big. Now, 100 milligrams is kind of your standard dose. But if I've got a bigger patient, I want to stay away from that 100. I'm going to do the 1 to 1.5 milligrams per kilogram. If I've got a head injury patient, 1 to 1.5 milligrams per kilogram. Now, pediatrics, they don't have the receptors. And so you might have to give them a higher dose. So it's usually 1 milligram per kilogram, but up to 2 milligrams per kilogram. I usually err on the side of I go to the 2 milligrams per kilogram on the kids. And the reason is again, they just don't have the receptors like the adults do. And again, your maximum dose thing, again, it kind of patient dependent. If I got a small patient, I usually don't ever go over 100. If I got somebody who's, let's say, 350 pounds, then I would definitely, that 100 milligram rule is kind of out the window on that one. All right. So we can give this IVP, we can give it IO. You can give it IM. The only time I've ever seen that actually done is when I had somebody really combative patient in the ER doc. He gave it IM, and 3 minutes later, boop, he was out. So, but again, most of the time we give this IVP at IO. Make sure you got a patent line before you give this stuff. You want to make sure that it's going to work. And I kind of throw this in there as dantrolene is what's going to use. We don't carry dantrolene. So if you've got somebody that has malignant hyperthermia, dantrolene is what's going to be needed. Call ahead to the ER. Say, hey, look, we gave sucks. We got him intubated, but now this guy is burning up. And if that happens, again, you got to cool him down. Very active cooling. But you got to let the ER know, hey, get the dantrolene ready because we're going to need it. All right, pregnancy class. Again, it does cross the placental variant. It can cause fetal damage. But again, at that point, we want to keep mom alive. That's our goal in life. All right, so again, succinylcholine. You got to know this one backwards and forward, guys. You absolutely have to know it. Watch this video a couple times. Make sure that you know all of those contraindications. Know that it causes a potassium shift. If you've got somebody with high potassium, stay away from it. All right, we will see you next time, guys. Sorry to go so long on this one, but it's kind of really important. See ya.